The topic of the focus or the topic of the discussion today is about the benign and the neoplastic lesions of the colon. But the main focus of the discussion would be about the colorectal cancer. There are different kinds of the benign diseases which can be encountered in case of the rectum. But most common, the benign lesions in case of the endometriomas or the haemangiomas or the gastrointestinal stromal tumors, they're basically not very common. But if you talk about the benign lesions, these are some kind of the lesions which can be found in rectal mucosa or the lumen of the rectum. So first we will be talking about the benign rectal lesions, and then we'll be talking about the neoplastic lesions, specifically the colorectal cancers, which are most of the time the adenocarcinomas. First of all, let's talk about the benign rectal lesions. There can be hemangiomas. Hemangiomas are the benign lesions or the benign tumors, which are involving the vessels. So most of the time, the patient of a colorectal cancer that presents to you with a PR bleeding, these hemangiomas, they remain undiagnosed because you keep on thinking about the other causes, like the the symptoms are more likely just similar to the hemorrhoids, like the PR bleeding, so they remain undiagnosed. But when they are diagnosed, like the usual appearance of the hemangiomas, they're not different from the carcinomas or the other kind of the metastatic cancers or the adenocarcinomas. But if they are being diagnosed, what we have to do is we have to go for the selective angiography and embolization. And or for the extensive hemangiomas, we have to go for the excision of the rectum. Most of the time, those hemangiomas, because we all know that hemangioma is a benign tumor of the vessels. So whenever a vessel is bleeding, whenever you're operating the hemangioma, the problem would be a persistent bleeding, a lot of bleeding. So for that, but if the hemangioma is small, you can go for the selective angiography and embolization. Or if there's extensive hemangioma, then you go for the excision of the rectum. The other benign lesions which can be found out in case of the rectal diseases, they're the gastrointestinal stromal tumors. These are particularly the tumors which are arising from the smooth muscle stroma. So, but most of the time, they can be anywhere in the gastrointestinal tract. So, in case of the stomach, in case of the duodenum, in case of the jejunum, but the most common location is the stomach. Other than stomach, the gastrointestinal stromal tumor can be in case of the rectal benign diseases. So most of the time they are leiomyosarcomas, and in case of the leiomyosarcomas or the gastrointestinal stromal tumors, you have to go for the complete radical excision of the rectum. There's another entity which are called as the neuroendocrine tumors, which are NET tumors. Neuroendocrine tumors, they are also not specifically located in a specific place, or they can arise anywhere, and their treatment depends upon the different kinds of the factors. But in case of the neuroendocrine tumors, which are metastasized, usually, which are not metastasized, they are localized to the specific organ, or they are localized to the specific place, and you go for the radical excision. But those neuroendocrine tumors which metastasize, they have to be treated with the adjuvant therapy. So this was about the benign lesions, and there's another entity in case of the benign lesion, which are the endometriomas, like the ectopic presence of the uterine mucosa elsewhere in the body. It can be anywhere. So rectum is another place where you can find the endometriomas. So this was about the benign lesion. They're not very common. They are rarer benign lesions. But if we talk about the neoplastic conditions, colorectal cancers, these are, let me tell you, these are the most important cancer because they are globally, they are the second most common cause of the cancers in the body. And if we talk about specifically men, so in men it's the third most important or third most common tumors in men, and second most common tumors in a woman. Worldwide or globally, they are the second most common tumors. In case of female, they're the second most common tumors, and in case of men, they are third most common tumors in the human body. So most of the time, they are not just involving the rectum, they are the colorectal cancers. That means they are involving the sigmoid colon as well and the rectum as well. The involvement of the rectum can be, it can be either a distal rectum or it can be a proximal rectum with a colon. The position or the location of the tumor is very much important because the resection of the tumor, the proximal or the distal resection of the tumor, that depends upon the location of the tumor. Like it's a proximal tumor with a colon or a distal tumor just involving the rectum, because in case of the distal rectum, you have to leave a margin of 3 centimeter distal to the cancer. And other than that, you have to go, in case of the proximal tumors, you have to go for the anterior resection and abdominal perineal resection in case of the proximal tumors. We'll be talking about the different kind of the surgical options we have available with us. You can see here in this diagram that this is basically the colon, and this is the rectum, and this is the part of the transverse colon, the splenic flexure, the rectum with the sigmoid colon, and this is the extent of the tumor. You can see here this is the anal canal, and this is the tumor which is just confined to the rectum, and there are also the lymph nodal involvement as well, and this is the rectal mesentery through which rectal mucosa is attached, and this is the anal opening. So colorectal cancers, I told you that they are the second most important cause of the malignancy worldwide, and there are different kind of the risk factors which are being responsible, like the age. Most of the time, a typical man greater than 55 years of the age will be presenting to you with a PR bleed. So for the first thing, you have to think in the old people, specifically male, you have to think about the colorectal cancers. So age is very important risk factor. Then you have some kind of the hereditary risk factors. Then you have the dietary factors, inflammatory bowel disease, cigarette smoking, and ureteric sigmoidostomy. Now, let's discuss these one by one. Age greater than 50 years, they are more prone to develop the colorectal cancers. You know, the risk factors or the cause of the colorectal cancer, it can be either spontaneous or it can be acquired, or the genetic or hereditary. The thing is this, that, you know, there is always a pre-malignant precursor lesions in case of the colorectal cancers, which with the passage of time develops into a malignant lesion. Now, this pre-malignant or precursor lesion, that can be either spontaneous or that can be acquired. But research, recent research studies, initially it was thought that maybe the hereditary factors are more important, but those spontaneous, we observed that the spontaneous cases are reported, not the acquired, but the spontaneous cases, they are 20% more as compared to the hereditary one. So if we talk about particularly about the hereditary risk factors, you know, there can be, it's like running in the families, and then the history of the inflammatory bowel disease. there's some specific genes which are involved in case of there's like the APC genes, which are the adenomatous, polyposis cancers, and plus there can be mutations in the TP53 mutations. And if we talk about the pathophysiology, WNT signaling pathway, this is very, very important, because actually there is some kind of a disruption in the WNT signaling pathway, and this leads to the accumulation of the beta catenin proteins. And whenever the beta catenin proteins, they are being accumulated, actually they activate some kind of the transcription factors for the proto-oncogenes. And when the proto-oncogenes, we know that they're oncogenic, and when they are overexpressed, they'll lead to the formation of the cancer. Similarly, the mutations in the TP53 genes, which are responsible for the apoptosis and cell death, which is the programmed cell death. So whenever TP53 mutation is there, apoptosis or the programmed cell death, that is affected. And the mutated genes, they pile up, they accumulate, and later on they develop into full-blown cancer. So if we talk about the risk factors, number one, aging. Number two, hereditary risk factors like running in the families, and inhibiting the factors like the mutated APC genes and mutated TP53. And there's another syndrome, which is the HNPCC or Lynch syndrome, which is hereditary non-polyposis colorectal cancers. And then you have the dietary factors like the food, which is not very much in a high fibers diet. The low fiber diet is also responsible for the colorectal cancers. In inflammatory bowel disease like the ulcerative colitis and the Crohn's disease, they are very much important, because in ulcerative colitis or the Crohn's disease, the mucosa actually, there are some other immunological mechanisms as well, but most of the time there is a recurrent chronic inflammation, and we all know that whenever there's a chronic inflammation and there's fibrosis, there's a chance to develop dysplasia or the pleomorphism in the new cells, and that leads to the colorectal cancer. Cigarette smoking is also one of the factor, and uretero sigmoidostomy, that is also important causative risk factor for the colorectal cancers. So if we talk about particularly the pathogenesis, I have already told you that they arise from the premalignant precursor lesion. This premalignant precursor lesion, that can be either acquired or it can be hereditary, and both lesions, they can be. Most of the time the lesions, they are involving the epithelium, and the lesion actually originates from the epithelium in the mucosa, but later on the lesion converts into a malignant lesion, and then it metastasizes as well. And it is because of the WNT signaling pathway mutations. And what actually this WNT signaling pathway does is actually, whenever there is a mutation that leads to the accumulation of the beta catenin proteins, and it increases the cell signaling activity. And whenever beta catenin proteins, they are accumulated, they activate the different kind of the transcription factors for the proto-oncogenes. And whenever the proto-oncogenes, they are overexpressed, they lead to the formation of the colorectal cancer. So initially what happened is like you got a premalignant precursor lesion in the epithelial lining of the colon. Then because of there's the mutations in the WNT signaling pathway that increases the cell signaling activity, and then that lead to the TP53 gene mutations, TGF, tumor transforming growth factor beta, and different kind of other transcription factors like the DCC, and they all lead to the overexpression of the oncogenes and the proto-oncogenes. And whenever there is an overexpression of the proto-oncogenes, or there is underexpression of anti-apoptotic or the apoptotic factors, that lead to the development of the colorectal cancer. And plus the other genes which are involved in the pathogenesis of this colorectal cancer is a KRAS RAF, and PI3K genes. And there's another entity, which are the APC genes, which are the adenomatous, polyposis, coli genes. So they're also responsible, because whenever there is mutations in the APC genes, ultimately there would be overexpression of the proto-onco and onco genes, and then there would be development of the colorectal cancers. So another good flow sheet to help you understand about the pathogenesis, like there was a normal epithelium, and somebody having the APC genes that will lead to the formation of the dysplastic epithelium. And then, the second step to the dysplastic epithelium is early adenoma. And then when there is a KRAS mutation on this early adenoma, that is converted into intermediate adenoma. And then there are some other factors which are like the DCC, JV18, they act and they convert the intermediate adenoma into the late adenoma. And then this P53 mutation, like there's no programmed cell death, or the apoptosis is affected. So this late adenoma wouldn't be destroyed at all. They would be converted into carcinoma. And then this carcinoma either will be localized, or there will be it would metastasize to some other places. There's some other genetic pathways, like the loss of the heterozygosity pathway, a microstellate instability pathway, and CpG-Alin methylation pathway. They are very complicated pathways to understand, but just you have to keep in mind the foremost thing you have to keep in mind is a WNT signaling pathway, and the other is a microsatellite instability pathway and loss of the heterozygosity pathway, and the CpG-Alin methylation pathway. Just have to keep in mind the different kind of the genetic pathways, but you don't have to go into the details for that. Now let's just talk about the different kind of the clinical features. First, I told you the typical case scenario would be an old age male, like maybe 55 years, coming to you with PR bleeding, and maybe there can be a PR bleeding with a mucosal discharge. Usually, the bleeding in case of the colorectal cancers, it's painless. Right? If the bleeding is associated with the anal fissure, the bleeding is a painful bleeding. But in case of the hemorrhoids and in case of the colorectal cancers, the bleeding is painless bleeding, and you cannot differentiate either the bleed is from the hemorrhoid or either the bleed is from the colorectal cancer, except until unless you do the DRE or you perform the proctoscopy. So a patient will typically say that I pass the blood with a stool, or either the blood is mixed with a stool, or he will say that when I finish the process of defecation, there is a stool in the commode, right? So it can either be mixed with a stool or just after the defecation. So bleeding, painless bleeding, is the first clinical feature of the colorectal cancers. Then there can be tenesmus. The tenesmus is like the sense of incomplete evacuation of the bowel. The patient will say that I passed the stool, but I feel that I still urge to defecate. I still need to defecate. There's still some stool left behind, and I need to defecate. That is called as the tenesmus. So tenesmus is another early sign of the colorectal cancers. The other thing is the alteration in the bowel habit. What do you mean by the alteration in the bowel habit? Like the patient will say, I have diarrhea, alternating with a constipation. Or the patient will say that I have early morning diarrhea. He will typically narrate that I feel abdominal cramps, and I feel to defecate whenever I get up in the morning. The first thing I need to do is to go to the bathroom and defecate. So this is the early morning diarrhea. This is a typical of the colorectal cancers. And the patient will also give the history of the weight loss. Usually, the colorectal cancers, they are not painful. The defecation is not painful, there's no abdominal cramps, but in the advanced cases, the patient can complain of the pain. So the typical features you have to keep in mind is the bleeding PR. That's a fresh bleed. Either it can be mixed up with a stool, or it can be there at the end of the defecation. The other thing is a tenesmus, that is an incomplete evacuation of the rectum. There can be alteration in the bowel habits, and it can be a spurious diarrhea or the early morning diarrhea. And there can be a history of the weight loss and pain in the advanced stages. So when a patient comes to you and gives you this kind of clinical features, or tell you about the kind of the symptoms he is experiencing, what next step you're going to do is you have to investigate, and you have to start from your clinical examination, and you have to start from the abdominal examination, and then you'll go for the digital rectal examination, or the proctoscopy, or the sigmoidoscopy, or the colonoscopy. So the first thing is, like, you have to examine the patient. Start from the abdominal examination, inspection, palpation, percussion, and auscultation. Sometimes, so if a patient is presenting to you with all the symptoms that I have mentioned earlier, and you need to investigate the patient, right? And for the investigation, you have to start from your examination skills. You have to start from the abdominal examination. Like, first of all, you have to go for the palpation, percussion, auscultation, and obviously the palpation as well. And then you have to go for the digital rectal examination. And after that, you have to go for the proctoscopy or the sigmoidocolonoscopy. So in case of the abdominal examination, what kind of the positive findings you can have in your abdominal examination? At times it happens that the rectum, that can actually cause the obstruction, the large intestinal obstruction. So in case of the large gut intestinal obstruction, the patient can present with a subacute or the acute intestinal obstruction. So there can be vomiting, there can be abdominal distension, right? So if you examine the patient, you're palpating the abdomen, you can find out that the patient has got the abdominal distension because of the subacute intestinal obstruction. So then you have to go for the rectal examination, and in case of the digital rectal examination, what you have to look for is there can be bleeding, there can be mucus discharge, there can be fresh bleed coming out from the anal region, or there can be by the tip of your finger you can palpate any kind of the mass which can be located in that premises. And if you can either check in the digital rectal examination whether the mass is tethered, or it is mobilized, it's mobile, or it is tethered or fixed to the skin. Plus, the other thing you can look up is for the surface of the mass. It's a smooth surface, it's irregular surface. It's kind of it gives you the idea that it's kind of a benign lesion, or it's kind of a polyp, or the ulcerated lesion. So in case of the ulcerated lesions, sometimes you can feel the pit, or sometimes you can feel the depression in the center of the lesion, and you can also feel the everted edges or the raised margins of the lesion. So that's why digital rectal examination is very much important. In at least 7 to 8 centimeters of the rectum, that can be palpated with the palm of your finger to the digital rectal examination. So that was the reason you need to perform the digital rectal examination. Plus, sometimes these tumors can metastasize. They can metastasize locally, right. In case of males, they can metastasize to locally spread to prostate. So you can also check out the hardened, roughened, irregular surface of the prostate. And they can also metastasize to the vagina in case of the female patients. So you have to palpate the posterior vaginal wall as well, because there can be a local spread to the posterior vaginal wall. So you perform the digital rectal examination, and in case of the female patient, always go for the vaginal examination, or the vaginal examination, because there can be kind of a metastatic or the local spread to the posterior vaginal wall. So you have to keep these things in your mind whenever you're performing this kind of the when you are actually thinking about the colorectal cancers. The other invasive, first you go for the non-invasive investigation, then you go for the invasive investigation. So if you are going for the non-invasive investigation, sigmoidoscopy and the colonoscopy is very much important. The gold standard is the colonoscopy, and you actually put the colonoscope and then you actually visualize the whole of the colorectal part, because if you do the sigmoidoscopy, you will only see the sigmoid colon in the rectum, but the colonoscope is a better option because you can visualize the stenting colon as well. And plus you take the biopsy and you send the biopsy for the histopathology in whatever the lesion, whatever dysplasia, or the kind of the cells of the cellular atapia, they can be found out in the biopsy. So after you have made a diagnosis of the carcinoma, you need to know that what kind of a spread there can be in case of the colorectal cancer. So it can be a local spread, it can be a spread through the venous system, it can be a lymphatic spread, or it can be the peritoneal seeding with the colorectal cancers. So one is about the local spread, which can be involve the posteriorly, sacrum and the coccyx, and anteriorly uterus, vagina, laterally ureters, and anteriorly there is the bladder as well. And in case of the males, there can be local spread to prostate, seminal vesicles, because these are all structures which are just anterior to the rectum. And there can be a lymphatic spread. And the lymphatic spread is along initially the early spread is to the pararectal lymph nodes, but in the later stages, what happens is the lymphatics or the spread is to the origin of the arteries from the aorta, right? And there can be venous spread as well, and there can be peritoneal dissemination as well. So 4 important route for the spread of the colorectal cancer: local spread, lymphatic spread, venous spread, and then you have the peritoneal dissemination. There's another classification which is very much helpful. That's the Duke's original classification, and then you have the Duke's modified classification. Duke's original classification is ABC, and Duke's modified classification is ABCD. So what is basically the Duke original classification? That is like the A is basically that the tumor is just confined to the rectum, and there is no regional, local spread or lymph node metastasis. In type B, the pararectal tissue is also involved, but there's no metastasis. There's just the extrarectal tissue is also involved. And there's another category, which is C, and C is basically CA and CB, or C1 and C2. In CA or C1, actually there's a regional metastasis to the lymph nodes, and in CB or C2, there is a distant metastasis, right? And the other modified Duke's classification that involves the D category as well, in which there's a distant metastasis. So this was about the Duke's original classification. Now, if we talk about the surgical treatment, you have to think about, there are some principles you have to follow. First of all, you need to look whether it's a proximal tumor or it's a distal tumor. And you have to go for the abdominal perineal resection, or you have to go for the anterior resection, or you have to go for the microscopic surgeries like the you're doing the endoscopic or transanal laser microsurgeries. So surgical treatment varies depending upon the extent of the tumors. Usually, at the T1, T2 stage. I'll be discussing about the TNM staging as well. So if the staging is at T1 and T2, you can go for the EMR, which is endoscopic mucosal resection. But in case of the tumors which are in the serosa, or they're extending far beyond that, and there's a lymph node metastasis and the regional metastasis as well. In all those cases, you have to go for the anterior section or abdominal perineal resection. The surgical options, there can be endoluminal stenting, there can be radical excision of the rectum, there can be external beam radiotherapy, or there can be, because sometimes you do the curative surgery and sometimes you do the palliative surgeries. Those tumors which are not metastasized that much and they can be resected, they with a course of radiotherapy or the chemotherapy. But sometimes, if the tumor is very small, you give them a wait and watch. You go there. There is a regimen which is called as wait and watch. In wait and watch, you give the chemotherapy or the radiotherapy for 6 weeks or maybe greater than that, and then you assess the size of the tumor. And if the tumor size is considerably shrinking, then you put the patient in a long course chemoradiotherapy. And almost 70% of the patients who are put on a long course chemoradiotherapy, they have got a good positive results. But all those 30%, rest of the 30%, which patients which are put on a long course chemoradiotherapy, they ultimately have to go for the resection. So endoluminal stenting, radial excision of the rectum, like the anterior section or the abdominal perineal resection, external beam radiotherapy, and then you have the short course chemoradiotherapy and the long course chemoradiotherapy, and a wait and watch policy. So if we talk about the other treatment modalities, I have told you that there is another transanal endoscopic microsurgery in which you actually, those lesions which are just confined to the mucosa or submucosa, and they're not metastasized, or there's no local spread, no regional metastasis or lymph node metastasis, and they're just confined to the local rectal tissue. You can go for the transanal, like you're going from the anal region, and the lesion is just is close to the anal verge, like 8 to 10 centimeter of the anal verge. So you can easily put the endoscope and you go for the microsurgery, which is very important and non-invasive technique. This is another, just the lesion was here, you go through the anal lesion, you put this transnasal endoscope and you just resect the lesion with a distal margin of 2 to 3 centimeter, and that's how you do the transanal endoscopic microsurgery, which is called as TEMS. There's another method in case of the anterior resection. So it can be either a double stapling method or it can be a single stapling method. They're kind of the techniques which are used in case of the anterior resection. What you do in an anterior resection we'll be discussing later in case of the surgical procedures, but you have to keep in mind that either you do the transanal endoscopic microsurgeries, endoscopic microresection, endoluminal stenting, or you do the anterior section by a single stapling method or a double stapling method, or you do the abdominal perineal resection. So in case of the double stapling method, what you do is you resect that particular segment. First of all, what you have to do is you have to mobilize the colorectal part. You have to separate it from the peritoneal reflection. You have to separate from the colonic flexure should be mobilized, so that you bring the colorectal part medially and you separate the mesentery as well. And then you do the rectal dissection. And rectal dissection is usually performed up to the extent of the inferior mesenteric artery, and then you separate it, you resect that particular segment, and then you do the end-to-end anastomosis or side-to-side anastomosis by a double stapling method or by a single stapling method. But for that, you have to make some pre-operative preparation. And in case of the pre-operative preparation, you have to correct the anemia and electrolyte imbalance or disturbance. Because whenever the patient is suffering from a colorectal cancer, the problem is he can't absorb a lot of food, right? And then because of that, there is, the patient develops anemia because a lot of the blood is lost parectally. Because of that bleeding, the patient develops anemia. So first, you have to prepare the patient. You have to build up his HB. You have to correct the electrolyte disturbances. You have to arrange some blood for the transfusions. You have to do the blood grouping. You have to perform all of the investigations, and then you have to go for the bowel preparation. Now, what do you mean by the bowel preparation? Like you have to keep the rectum empty of the stool, and for that you have to put the patient on a total parenteral nutrition. Actually, you calculate the carbohydrate, proteins, and the amount of the lipids which can be required by a body or by a patient according to the weight and the BMI of the patient. And you put the patient on a total parenteral nutrition. You prepare the bowel at least 3 days before the surgery. You put the patient on purgatives. You give the patient a clean enema, and you give the laxative so that the bowel is actually free of any kind of a stool or fecal material. And plus, you also give the patient a clean enema, and you do the bowel preparation and put the patient on a total parenteral nutrition, building up the good electrolyte control, building up the good glycemic, carbohydrate, and protein, because there's a lot of wasting and there is a lot of weight loss in the patients. First, you have to build up the patient, and you have to put the patient on a DVT prophylaxis, start the patient on a heparin or a minimum dosing of the clexane, like the maybe 20 milligram or 40 milligram subcutaneous OD clexane would be sufficient for that. And you also put the patient on a prophylactic antibiotic. You usually in the US and the rest of the world, broad spectrum antibiotics are given. So usually you get the patient on a broad spectrum antibiotics prophylactically. But about the anterior section, I told you there can be multiple options which can be performed. Anterior section means that actually you are anteriorly resecting the rectum. You can see here that actually this is the anal canal. This is a part of the anal region, and there is a lesion which is probably the cancer, the colorectal cancer. But in case of the distal rectal cancers, you do the anterior section. First of all, you mobilize the part of the rectum, you get rid of the peritoneal reflection, you mobilize it to the pelvic floor and the extent of the inferior mesenteric artery, and you do anteriorly, you just resect the rectum anteriorly, and then you do the end-to-end anastomosis or the side-to-side anastomosis with a double stapling method or a single stapling method, and you do the anterior section. There's another procedure which is transanal total mesorectal excision, and that's for the lower rectal cancers and which are confined to that particular part and they're not metastasized. And there's another surgical optional procedure that is abdominal perineal excision of the rectum. Usually, what happens is usually those tumors which are just in between the rectum and they're not extending to the anal canal, there can be a sphincter salvage procedures in case of the anterior section. But in case of the colorectal cancers, you go for the abdominal perineal excision. Actually, this procedure took place. There were two surgeons which are operating on a colorectal cancer. One started from the abdomen and another started from the perineal region, and they were independently operating. But nowadays, there's one surgeon. He starts from the abdominal. He completes the abdominal resection or the abdominal dissection, and then then after completing the abdominal dissection, he goes for the perineal dissection. But in case of the abdominal, the extent of the dissection or the plane between the rectum and the other organs is like up to the inferior mesenteric artery. But in case of the abdominal perineal, the lower extent should be on the pelvic floor, till the pelvic floor. And distal 3 centimeter margins should be left in case of the colorectal cancers. You can see here, abdominal, this is resection is completed, and then perineal resection is done through the anal opening. This is the abdominal perineal excision of the rectum. And there's another for the tumors which are metastasized to the uterus or vagina or the different kind of the pelvic structures. There's another procedure which is called as a pelvic exenteration, and we perform this pelvic exenteration for the metastatic lesions like the local spread. Other treatment options, they include the endoluminal stenting. There can be, because those tumors which are metastasized, because most common sites for the metastasis are the liver, lungs, and the adrenals. And those tumors which are metastasized to these organs, and the tumor has a greater local spread or the venous or the lymphatic spread, you can't just go for the curative surgery. So you do the palliative colostomy, in which actually the tumor part is resected, and the permanent colostomy, the patient is put on with a permanent colostomy. And for sometimes, there can be a single lesion in the liver, or there can be multiple lesions in the liver. So single lobe resection or the complete liver resection that can be performed in case of the metastatic diseases. And you can put the patient on a radiotherapy and the chemotherapy for the advanced tumors. So in case of the inherited colorectal cancer, the most important cause is a familial adenomatous polyposis. And in case of this, you can see here there are multiple polyps, and they are involving the whole of the colorectal part. So in case of the familial adenomatous polyposis, there is increased risk for the malignancy, and there is complete resection of the colon and the rectum. And then you put in an artificial permanent colostomy is established. Familial adenomatous polyposis is a rare autosomal dominant condition, and there is familial adenomatous polyposis coli genes, and the mutations obviously lead to the formation of the colorectal cancers later on in the life. So mainstay of the screening should be a flexible sigmoidoscopy every 6 months, so that in case of dysplasia or malignancy, that can be find out earlier. And APC gene testing is also another screening test that can be those patients who have APC or FAB gene positive, they have more increased risk for the adenomas. And for that, you go for the total abdominal colectomy with rectal anastomosis, or you put the patient on a permanent colostomy like the total proctocolectomy with an embrochiostomy, or you go for the restorative proctocolectomy with ileal pouch anal anastomosis. And in case of the attenuated familial adenomatous polyposis, there can be mutations in the APC and MHC gene. The pattern would be in a autosomal dominant pattern. And for the testing, you go for the genetic counseling and other tests. And for prophylaxis, you put the patient on a COX-2 inhibitors, and you also do the colonoscopic snare excision. There's another entity which is called as HNPCC, or the syndrome, which is hereditary non-polyposis colorectal cancers. One entity was about the familial adenomatous polyposis, in which the inherited disease later develop into the colorectal cancers because they have that APC or FAP gene. But there's another syndrome, which is the Lynch syndrome, and in case of the Lynch syndrome, there's a microstellate instability pathway, W anti-signaling pathway, and this hereditary non-polyposis colorectal cancers then later develop into full-blown colorectal cancers. So they arise from a mismatch repair, and most of the time the mutations are involving the MHC6 or PMS2 mutations, and they're diagnosed on the basis of a family history, but there would be no association with the APC or FAP gene, or you have to put the patient in an Amsterdam criteria, and you have to put the patient in a screening colonoscopy every 6 months. And for this kind of the syndrome, you go for the total colectomy with the ideal rectal anastomosis, a hysterectomy, or bilateral salpingo-oophorectomy. So in case of the familial colorectal cancers, they can be non-syndromic familial colorectal cancers, and there is increases with the family history, but not necessarily like they have the syndromic kind of the history of the familial colorectal cancers. And again, the main stay for the screening is a colonoscopy, and in such kind of the patients, there can be defects in an LOH or MSI pathway. These are not so important. The only thing you have to keep in mind is a spontaneous lesion, or this is kind of acquired in case of the familial adenomatous polyposis or the Lynch syndrome. So how you are going to prevent kind of the tumors, and what kind of the screening modalities we have. The first mainstay is a colonoscopy, sigmoidoscopy, and there can be double contrast barium enema. These tests should be frequently performed like every 6 months, so that if the dysplastic change in the cellularity pattern, or even if the lesion is increasing in size, that should be noticed. So let's just discuss about the screening guidelines in case of the average risk and in case of the colorectal cancers. So colonoscopy should be done every 10 years. There should be annual FOBT, flexible sigmoidoscopy, every 5 years, and there should be air contrast barium enema every 5 years, right? Annual FOBT or flexible sigmoidoscopy every 5 years, air contrast barium enema every 5 years, and colonoscopy every 10 years for the average risk. But in case of the colorectal cancers, there should be pre-treatment colonoscopy after 3 years, and colonoscopy every 5 years if there is no lesion. And other screening guidelines, in case of the adenomatous polyps, colonoscopy at first detection. Then if there's no further polyp, then colonoscopy every 5 years. And if there is a polyp, the colonoscopy every 3 years. And annual colonoscopy for adenomas greater than 5. And in case of the familial adenomatous polyposis, annual flexible sigmoidoscopy and upper endoscopy every 1 to 3 years after the polyp appear. And in case of the ulcerative and the Crohn's colitis, colonoscopy with many biopsies every 1 to 3 years. In case of the hereditary non-polyposis colorectal cancers, colonoscopy should be every 1 to 2 years, and endometrial aspiration biopsy should be 1 to 2 years. In case of the FAP, familial adenomatous polyposis, and attenuated FAP, annual flexible sigmoidoscopy, upper endoscopy every 1 to 3 years should be performed. So about the real root of the spread of the colorectal cancers is the venous spread, or it can be a local spread, or it can be just involving the kind of the peritoneal dissemination. So the lymph nodes are along the vessels most of the time. You can see a middle rectal, inferior rectal, and the superior rectal. These are the blood supply, and the venous drainage ultimately goes into the splenic veins. And you know that the lymph nodes accompany the arteries, So actually, initially pararectal cancers, pararectal lymph nodes are metastasized, and later on, the lymph nodes along the origin of the arteries, they are being, they are later on metastasized. The clinical presentation is again abdominal pain, bloating, change in the bowel habit, rectal bleeding, and the left-sided tumors. They can also present with a subacute intestinal obstruction, and there can be weight loss, anemia, or poor appetite. Staging of the tumor is very much important because the extent of the surgery, that depends upon the TNM staging. For the staging, CT is the mainstay, and for a local spread, you have to go for the ultrasonography, endoscopic ultrasonography, and positron emission tomography, which is the PET scans. They're also important for the staging. So let's just we'll discuss about the tumor, and for the nodes, and M for the metastasis. So Tx is the tumor cannot be assessed. T0 is there's no evidence of metastasis. There's no evidence of the primary tumor. TIS stands for in situ, that the carcinoma is in situ, like intraepithelial or just involving the lamina propria. T1 tumor invades the submucosa, and T2 tumor actually invades the submucosa and then muscular mucosa, and T3 tumor involves the surrounding structures, and T4 is around the distant spread of the tumor. So you can see here that this is a bowel, this is the lumen, this is the inner lining, this is the outer lining, muscles in T1. So T1 tumor is just involving this just involving the mucosa, the lamina propria. T2 is involving the submucosa, T3 is involving 3 layers up to this, and T4 is just involving the adjacent structures as well. This is the T4, T3, T2, and T1 staging. So let's discuss about the nodal metastasis. NX is like no nodal metastasis can be no nodal involvement can be assessed, which is NX. N0 is no lymph node metastasis. N1 is metastasis to 1 to 3 pericolic or perirectal lymph nodes. N2 is metastasis to 4 or more lymph nodes, and N3 is metastasis to any lymph node which is adjacent to the major vascular trunk, like the aorta, right? So NX is regional lymph nodes cannot be assessed. N0 is no nodal metastasis. N1 is metastasis to 1 to 3 lymph nodes involving the pericolic or the perirectal lymph nodes. More than 4 more than 4 is N2, and N3 is to the major vascular trunks are involved. And metastasis, MX is presence of distant metastasis cannot be assessed. M0 is no distant metastasis, and M1 is a distant metastasis present. So MX was the distant metastasis cannot be assessed. M0 is there's no distant metastasis, and M1 is basically obviously distant metastasis is present. If we talk about the preoperative evaluation of the colorectal cancers, we need to do the TNM staging, right? And for that, we have to go for the endorectal ultrasonography or magnetic resonance imaging. Endorectal ultrasonography tells us about the local extent of the tumor, like the mucosa, submucosa, serosa, or the adjacent structures, and MRI tells you about the distant metastasis. Digital rectal examination for the rectal cancers. You also go for the chest, abdominal, or pelvic CT scans. Another modality for the tumors to rule out the distant metastasis is a PET scanning or CEA, which is a tumor marker, a very important tumor marker, and that is a carcinogen embryonic antigen. So you have to go for the therapy of the colonic carcinoma, but it should be a stage specific therapy. First, you do the TNM staging, then you do the staging or the grading of the tumor, and then you go for the specific stage specific therapy. In case of the stage 0, you go for the segmental resection or the endoscopic removal and excision. In case of the stage 1 resected, the tumor should be endoscopically resected, or there should be segmental colectomy. In case of stage 1 and stage 2, the patient should also be put on adjuvant chemotherapy or radiotherapy for the selected patients or the selected cases. So in stage 0, you go for the endoscopic removal and excision. In stage 1, you go for the segmental colectomy as well. And in stage 1 and 2, you put the patient on adjuvant therapy as well. In stage 3 actually, you put the patient on adjuvant chemotherapy, and the drug of choice for that is oxaliplatin, or the other one is a 5-fluorouracil based regimens. And stage 0, patient should go for the metastatectomy. Like, if their metastasis is to the liver, there should be liver resection. And plus, you have to put the patient on the adjuvant chemotherapy. And in case of the stage 4 tumors, which are, there is the extent of the tumor spread is so far away that you can't go for the local resection. You go for the palliative surgery, not for the curative surgeries. For the advanced tumors, the treatment option should be palliative surgery. And the palliative surgery is like, there can be bilateral salpingo oophorectomy, a mentectomy, and plus the colorectal excision, and also metastatectomy with chemotherapy and the radiotherapy, and there should be angiographic embolization as well. Local therapy for the rectal carcinoma is like the transanal excision. There can be transanal endoscopic microsurgeries, or there can be excisional biopsy of the smaller lesion. Plus, this was about for the lesions which are smaller in size, which are just involving the lower rectum. But in case of the upper rectum, which are also extending to the or involving the middle rectum, you have to go for the radical resection. And the radical resection can be total mesorectal excision. There can be pelvic exenteration, or there can be, because sometimes the tumor metastasizes to sacrum, and you know that there's a sacral plexus as well, so you go for the sacrum resection as well. I have discussed almost all these things previously, the procedures for that. For the rectal cancer, there's also, state-specific therapy, and most of the time, the rectal cancers are the adenocarcinomas. So on the basis of staging, evaluation, CT scan, abdomen, pelvis, endorectal ultrasonography, what you do like in stage 1, you go, if the stage 1 is high risk, or the patient refuses the radical resection, and in case low risk, can accept the radical resection. So stage 1 tumors, you can go for the radical resection, or if you can't go for the radical resection because the patient is not willing for the radical resection, you should go for the endoscopic microsurgeries, right? And in case of the stage 2 tumors, because their extent is far more than the stage 1 tumors, so you go for the neoadjuvant chemoradiation therapies. In stage 3, there's a local resection plus the neoadjuvant chemoradiotherapy. And in case of the stage 4, again, you go for, if the patient is asymptomatic, you don't go for any kind of the surgical option, or in case of the symptomatic patient, you only go for the palliative surgeries. So if the patient is not willing for the radical resection, you go for the I told you, transanal resection or the endoscopic microsurgery with the neoadjuvant chemotherapy or the radiation therapy. And if the patient is willing for the radical resection in case of the stage 1 tumors, you go for the radical resection. In case of the stage 2 tumors, you either restage, there's no metastasis, then you go for the radical resection. And in case of the stage 3 tumors, you put the patient on a chemotherapy and a radiotherapy. You go for the wait and watch response, or either you go for the long course chemotherapy. If you restage and there's no metastasis, you go for the radical resection. And in case of the advanced tumors or stage 4 tumors, you put the patient on a chemotherapy because they can be, multiple unresectable metastatic sites. You have to put the patient on a long-term chemotherapy. And in case of a resectable or single metastatic site, you go for the resection along with the chemotherapy. And in case of the advanced diseases, you go for the palliative procedure, you go for the stenting, you go for the laser ablation, stoma resection, combined with the chemoradiation therapy. So, survival rate of the tumor, that depends upon stages. Usually, tumors which are limited to the mucosa or submucosa with a complete radical resection, the success rate is about 90%. But in case of the 2, 3, and 4 stages, they're since advanced stages. So in case of the early, the survival rate is about 5-year mean survival rate. So this was about the colorectal cancers. Independently, the colonic cancers and the rectal cancers, we talk about the different kind of the causative agents like the spontaneous or the acquired, and we also discuss about the treatment modalities. So thank you for watching sqadia.com. Keep watching sqadia.com.